Happy New Year, everyone. Welcome to 2025 and SADS Live. It's great to get to be with you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and our Winland Smith Rice Sudden Death Genomics Laboratory. But as in the previous 158 episodes and now our 159th, I'm here on behalf of the Sudden Arrhythmia Death Syndromes Foundation, the SADS Foundation, your nonprofit organization devoted to families like yours with a sudden cardiac arrest predisposing genetic heart condition. And whether yours is long QT syndrome, Brugada syndrome, CPVT, ARVC, laminopathy, whatever it is, I hope you feel that this is your home. And so here I give you greetings in the new year from Alice Laura, our CEO. And I've had the privilege of working along her side for many years now. I joined the SADS board in early 2001-ish, became its second president of the board in 2006. And so it's great to be with you. It's great to usher in the new year and to have our first SADS Live together in 2025. So if you joined us in the United States, great to have you on afternoon time. If you're across the pond in Europe, it is about 8 p.m. in the evening if live. And if you're down under there in Australia, good morning. And I guess in Japan, since my daughter was just there, it's 4 in the morning. So that would be early for you. But wherever this finds you, either live or on replay, great to have you with us. We are in Health and Wellness Month. That is January, Health and Wellness Month. That probably has to do with those New Year's resolutions. And I guess today, did you know, fun fact, I didn't know that today is the second Friday of January, which means apparently the second Friday of January is also known as Quitter's Day, where those resolutions have already failed and we've quit them. I hope that's not any of us. For me, it's not me. I have 3 resolutions of the new year, and I'm still doing all 3 faithfully. And so hopefully, whatever your New Year's resolution, you are a victor and have not succumbed to Quitter's Friday, which is, I guess, the second Friday of January. So Health and Wellness Month is what we're about, and we get to do your questions and answers, and they're starting to come on the screen. Remember the rules of the past and the present. Brief, tight questions so I can glance over, see them, process them. My rule is I take them in order. I've not seen any of these. No practicing, no pre-question Googling, just in real time, no chat GPT, just in real time. So I try to do my best to match the quality of your questions with a decent answer. Remember, there is no patient-specific advice. I'm not speaking into your specific situation that your question is reflecting, but using that to comment on the issues at hand. There's no way I could give you direct advice. Patients like that would be a 90-minute to 2-hour session after 2 days worth of testing. So I don't want us or any of us to pretend that this is direct advice. So here we go. In the new year, the first question is from Anne. Anne gets the first question of 2025. Does reaching a high heart rate like 190 plus during exercise pose a risk to patients with long QT syndrome? Great start to the year with a great question in Health and Wellness Month. And I love speaking about exercise and sports and a SADS condition. We've worked for this. This is a chapter in a book, one of my New Year's resolutions called Yes, You Can, because for many years, the word has been, no, you can't, don't. And when I joined the staff of Mayo Clinic in 2000, I raised my hand like Tom Hanks in that incredible movie, Big. When remember in the office, the corporate office, he says, I don't get it. I do not get it. Why are we doing it that way? And that's how I view this issue. And I felt then and do now that we should be empowering our patients to live large, to thrive, and to not live in fear. So to your question, I have never for a long QT patient, as in never given them a heart rate ceiling as to a heart rate that they need to keep their heart rate under. Never. So if you hit 190, great. In fact, if a person were to hit 190 on a maximum stress test, I would actually wonder briefly, I would need to be convinced that they even have long QT syndrome, because most long QT syndrome patients with true long QT syndrome cannot naturally reach their age and sex predicted maximum heart rate. So no ceiling. Now, CPVT patients, that might be a little different, because there's some beautiful data that's come out of Norway, in particular from a dear friend, Dr. Christina Hauge, showing that we might be able to train the CPVT heart a bit. In other words, if we saw that the CPVT bad beats came out at around a heart rate of 150, we would give them a 150 times 90% or 135 beat per minute heart rate ceiling. And what we might learn from that exercise is that the next stress test a year later, the skip beats may not come out at 150. They might now come out at 160, 170. So that's a disease, CPVT, where I might be counseling about a heart rate target to stay under during their workouts. Love that question. We could do that question for a whole nother 30 minutes. Next, though, does someone who is on a beta blocker get the same cardiovascular benefits from exercise as someone who is not on beta blocker? I'm on Nadolol and I never reach my target heart rate. No, you'll never reach your target heart rate in that Orange Theory class, right? With the orange zone or your workout zone, and you'll be with your buddy and you'll say, why is their heart rate 160 in the orange zone and mine's 120 or whatever? That's the beta blocker. That's what a beta blocker like Nadolol does. It decreases your maximum heart rate. That's how we know that there's a decent dose of beta blocker circulating in your system. And so does that mean you don't get the same benefits? Well, yes, it sort of means that, doesn't it? Because if my maximum heart rate during that 30-minute aerobic class is 120 and hers is 150, guess who's burning more calories? That's right, she is. So you may have to work out harder to get the same caloric burn expenditure. That's why some people find it more difficult to lose weight on beta blockers. Not impossible. I have plenty of patients who are at good body weight on medicine, but beta blockers can pose a challenge to weight loss, make it easier to gain weight. 2 in a row, a third from Jessica. Can these genetic mutations in the channels, not sure if I'm saying that correct, affect other areas functioning besides the heart? Oh, great question for number 3 from Jessica. And you said it perfectly. And we've learned a lot about, are these genetic channelopathies that are supposed to be long QT syndrome only, meaning the heart only, is it really the heart only? And we're starting to see some signals, nothing that's concerning really or important in the sense of, for example, we know that the potassium channels encoded by the LQT1 and LQT2 genes, that they actually are expressed in the beta islet cells of the pancreas, and they have a minor role in insulin secretion. We know, for example, that patients with Dravet and Lang-Nielsen syndrome who have a double dose of an LQT1 mutation that's made them deaf, that also affects certain cells in the gastric, so-called chromatin cells. You don't need to know that. What we do know that's kind of important is LQT2 patients where the LQT2 gene, KCNH2, also expresses that same potassium channel in the brain, particularly the hippocampus. And it is possible, not proven convincingly, but possible that a person with an LQT2 mutation could have true epilepsy and not just an LQT2 danger rhythm that then secondarily makes their brain go into a seizure. We know that the CPVT channel, the RYR2 gene that builds the ryanodine receptor, also called the calcium release channel, that builds that same channel not only in the heart, but in the brain. And we've learned that a subset of our CPVT patients have a learning disability ranging from mild cognitive impairment to autism spectrum. And so that calcium mishandling that occurs in the heart could also be occurring in the brain. So we're learning lots about, and of course, our families with the really super rare 1 in 1 million, 1 in 2 million disorder called Timothy syndrome, that there's a reason why that calcium channel mutation can cause syndactyly and can cause other neurological conditions, because besides being its impact on the ion channel, it has other impacts on other intracellular signaling pathways. So that was a beautiful question, Jessica, and a great one to be 3 for 3 for 2025. And hello to Germany. Guten Tag. Great to have you join us. And then our next one is, what if I don't have any heart disease? The genetic test came back negative and I have NSVT. Are there extra precautions? What about sport? Should I have a cardioverter be used? Good. And no, you don't have to apologize for your English. That question was perfect. I think whenever I have a family where they have been evaluated for long QT syndrome, maybe it's running in the family, and their own personal test is negative for that family's mutation, I then, before I dismiss them, I ask them what's their story. And so if for whatever reason there's been an evaluation for something else that has been found, and in your case, that person is said to have something called NSVT, non-sustained ventricular tachycardia, now we have a different issue. Now, that person is not part of a long QT family. They're a patient where we have to figure out whether that NSVT is important all by itself. What kind is it? Why is it there? What was it caused by? Am I concerned? Do I need to treat it? So now, even though that person gets to be dismissed from the family condition because they were tested negative for the family mutation, they become a new patient for their entity. Next is back to sports. What sports are considered safe with a SADS condition? Oh, great one. How about every sport? For me, I'm not worried. Now, this is disease specific. So for my long QT patients, honestly, I'm not worried about hardly any sport. Now, are there some caveats to that? Of course. What about swimming, you say? Swimming in LQT1, didn't we learn about that? Well, yes, we did. We published it. But that swimming link is almost always how the person, the swimmer, or the family, because of a drowning, got discovered. Meaning they were discovered because of the swimming LQT1 link when they were undiagnosed and untreated. After good treatment, is that swimming connection still precarious, spooky, dangerous? Not really. And a swimmer is back and forth, back and forth. Would I let that LQT1 person or tell them, go ahead and go do ocean swimming with the sharks? Probably not. So there's very few sports that I'm actually concerned about. Now, all of my athletes, I require an automatic external defibrillator as part of their sports safety gear. Even though, guess how many times we've had an athlete who's been diagnosed where he or she has then needed an AED, external defibrillator rescue? 0 to date. 0. So I require it, which makes it a little bit cumbersome, doesn't it, for certain sports? How about that long distance runner? Who's running with it? Where is it? How about that elite downhill skier, where is that AED, and so forth. So where a rower, who's rowing with it next to them out on the water. So sometimes the logic and the safety net breaks down a bit, but I don't really worry about them. Do I worry about sports with Brugada? No, pretty much zero. The only thing we work on is making sure if they are an elite football player down in the South USA in hot two-a-days, that we don't overheat and now have increase in core body temperature, not the workout necessarily, but the increase in core body temperature potentially be Brugada irritating. Am I concerned about sports with CPVT? Not that much, not after diagnosis. So am I concerned about anything? The one where I think the evidence is quite good, and this is really thanks to our colleagues at Johns Hopkins, and where they have done a really impressive job over the years raising the concern in humans and in mice, but it's gone from mice to men and mice to women, that long distance endurance training sports, so a log of sport activity, marathons, triathlons, long distance cycling, rowing, etc., could activate and agitate PKP2 mediated ARVC, the most common genetic subtype of desmosomal ARVC. So do I like my ARVC athletes to be marathoners? No, I try to have them not be. Our shared decision making always results in them saying, you know what, I agree, that's not a great idea. But do I make them be couch potatoes and confine them to a sedentary existence? I've never done that. I don't agree with that approach. Even PKP2 ARVC, if they're an athlete, I try to figure out how we get to keep them that. Now, if the person's not wired to be an athlete, do I need them to be an athlete? No, I don't care. I always ask my patients to get to know them. Answer the 3 A's. Are you an athlete? If so, what sports? Great. Are you an artist? If so, band, music, choir, dance, drawing? Great. If not, are you academic? What's your favorite subject? So I don't need my patients to be athletes. That's a myth that's out there. Let's debunk it. I love all of my patients, whether they're an artist or an athlete. But I don't fear sports, so I don't talk people out of most of their sports. My last patient an hour ago, triple sport athlete, football, baseball, basketball, and he tells me he's going to be a professional football player for the Kansas City Chiefs. Let's find out if that's true for this 13-year-old going forward. Good one. And Louise, hi. Well, hello back, and Happy New Year to you as well. What's the significance of PACs, premature atrial contractions, after exercise? My heart rhythm after exercise remains high, 100 beats per minute for about 2 hours. Well, those kind of irregular beats are PACs, which means for whatever reason, the top chamber, the atria, is still beating with extra beats being activated. That's different than a PVC, where it's sort of a rogue impulse coming from the bottom chamber, the pumping chamber, the ventricle, that's giving that premature beat. PACs, for the most part, are not that concerning. PACs are almost never part of the package deal for our patients with any of these SADS conditions. So I'm not too interested or worried. I'm interested in everything. Worried, not so much. And I would be exploring, if somebody is feeling those, sensing those, be doing additional evaluation. Somebody from Instagram world is asking, should they be wearing a heart rate monitor when I exercise? If so, what type is best? I don't know what type is best. I don't wear one. My son does. I could ask him what he likes for his workouts. That's Nicholas, number 2. He's got the one around the chest, but he's into weightlifting and trying to look like his dad. No, so I don't need you to wear a heart rate monitor. Some people like them. Some people like monitoring them for their own conditioning regimen. The one potential exception is, as I mentioned, maybe our CPVT athletes, if I prescribed that exercise heart rate ceiling as a treatment or a preventative strategy. That's the one setting where I've told them, you go ahead and get your favorite monitor. An announcement. So a pause from the question is, it indeed, as part of January's Health and Wellness Month, the SADS Foundation is putting on 2 webinars. Webinar number 1 is Build a Healthier You in 2025. That's on January 14th. That's going to talk about holistic strategies, just wellness strategies. And then January 28th with the co-PI and really my boss of the LIVE program. Some of you participated in LIVE Long QT Syndrome, LIVE HCM. This is our NIH-funded prospective study that I did with Rachel Lampert and Charlene Day. Rachel Lampert, the lead PI, were the co's. She's going to be joining you to have a discussion about exercising with SADS condition, and she'll amplify on some of the points and some of the lessons that you've helped teach us from that 3-year prospective study. And that's January 28th. Scrolling on down from Dark Moon. That's a cool name. What about hiking and long QT syndrome type 1 on beta blocker? I'm not worried about hiking. At some point, people have to live life and say, we're treated. And therefore, if we're treated, I can go on a hike. Now, would we hike in the middle of nowhere with or without an AED? I guess that becomes a decision for the family structure as to what would give them greatest peace of mind. I suppose that's similar to if I went hiking in Yellowstone, would I have bear repellent or whatever, or would I go without it? There is a theoretical increased risk. There's an antidote counterattack strategy. I can think of one family where and I can't remember now if it was after diagnosis and treatment or if the collapse during the hike in the middle of nowhere is how that family's SADS condition story got started. But I'm not worried in general about it. Marco's getting back to ARVC. Does total amount of exercise matter as much as intensity? Would long walks daily 2 hours be detrimental? Oh, that's a good question. I think there is virtually zero risk in even PKP2 of somebody getting heart healthy 10,000 steps in a day. Now that's real walking, isn't it? That's one of my goals. Is 2 years in a row I've been above 10,000 steps on average for the year. I increased it in 2024 compared to 2023. My goal was always 10,000. So this year, I'll tell you, my goal is for 2025, it's one of my New Year's resolutions, is 11,000 steps. So I wanted a 10% increase above that target. Turns out to do 10,000 steps, isn't it? It is about, for my stride, it's about 1,000 steps every 10 minutes at 3 miles per hour. So to do 10,000 steps, that's 100 minutes of walking. So 2 hours of walking would be about 12,000 steps. The thought that walking at 3 miles per hour would be disease activating is zero. That goes in mythology territory. So people should be walking, should be active. It really has to do with sort of a cardio aerobic load on the heart, where we're tasking the heart in a chronic high endurance fashion. So you're not walking when you're doing a marathon. You're not walking when you're doing a 50-mile cycle, Tour de France type training. So it's more the intensity of the endurance session, not just good heart healthy activity. So my thought of 2 hours walking, which would be 12,000 steps, being detrimental, I would put zero concern on that. Can someone with long QT1 participate in cross-country running? Oh, great question, Laura. We have had incredible questions for starting this new year. So again, I think the cross-country issue and the LQT1 or LQT2 or CPVT, really has to do with, does my safety drill work? Does my what's called emergency action plan, EAP, work? So that's why I am way more comfortable with my swimmers with LQT1. Yeah, swimmers with LQT1, because they're going back and forth 50 meters, confined audience, rescue plan right there. Whereas cross country, we're running here, there, everywhere. And so do we have a cross country AED chaperone? And so there I would have to put it in, it depends. What kind of LQT1 person am I talking about? Am I talking about one who's a LQT1 positive family member where we wouldn't even know they had it if it weren't for the genetic marker test because their ECGs look great? Well, that LQT1, I think we have way greater buffer than, am I talking about a fragile LQT1 who's at high risk, who even despite therapy continues to prove that we don't have their LQT1 under good enough protection? Would I want that person doing cross country unattended? So that's where it would, the correct answer would be, it depends. Sam was telling me that their 15-year-old son has CPVT and a pacemaker. So I'm guessing that means the pacemaker also has the ICD or the defibrillator component, because it would be very unusual to have the pacing function pacemaker all by itself. So let's assume ICD as well, the defibrillator. He's on propranolol and flecainide, and PVCs begin at a heart rate of 150 during the stress test. How much physical activity is safe for him? Well, I won't speak to what's safe for Sam. What I will tell you is that in my program, my strategy for all of my CPVT patients is to cure their stress test. So when somebody tells me that the stress test of a diagnosed person on treatment is that they have PVCs at a certain heart rate, that tells me that my job's not done, that I don't have the substrate neutralized well enough. We know from data that in CPVT, if you have continued exercise-induced couplets or more, then that's a predictor of future risk, that we're definitely not treated well enough. That observation has made CPVT experts throughout the world say to ourselves, why would we then just accept PVCs in Bigemini continuing throughout the stress test? That's every other beat. That's what Bigemini means. And so over time, we have learned and chosen that we should try to clean the stress test to where I could never, ever even make the diagnosis if I didn't know of the person's status. So I try to make that person's stress test completely normal. Will I accept one PVC during the stress test? Sure. But if I have PVCs frequently and PVCs every other beat, then my job's not done. And so I would be up titrating therapy, increasing the medicines of choice, and making sure they're at good doses. So depending on Sam's size, a person's size, 50 milligrams of flecainide, that can be viewed as a potential light dose. So I might have room to make that medicine stiffer to get a better result. Once I like the CPVT patient stress test, then I really let them do almost everything they love. So the first part is not which ones are safe, but do I like the quality of the stress test on the therapy? Have I liked what I have therapeutically achieved with the medicine to make their stress test look normal like mine? Caitlin's wondering whether beta blockers impact the QTC, and specifically probably wondering, do the beta blockers make the QT shorter, better? And there, I would say depends on which beta blocker. For Nadolol, probably not. For propranolol, potentially yes, and potentially yes in those with either LQT2 or LQT3. And that's because propranolol, besides it being a beta blocker, it also is a bit of a mimic in its chemistry for mixilotine, or a late sodium current blocker. So if propranolol is shortening the QT interval, it's because of that chemistry, not because of its beta blocker chemistry. The other thing that gives the impression of the beta blocker shortening, and this has been something we've learned, is you get an infant, they get their first ever QTC, it's wow, and then we treat them, and then their next one, when they're 2 months old, 3 months old, it's wow less. And we say, wow, that beta blocker shrunk the QTC. Not so fast. What's probably has happened is that almost always a person's first ever ECG, as long as there's not QT prolonging exogenous things in the mix, that person's first ever ECG is notoriously their longest of all of their ECGs longitudinally throughout life. And so especially in infancy. So when we have chosen to wait before starting the beta blocker, what we've seen then in the followed up infant untreated, that their second ECG shows a much shorter QTC, for which had they been on the medicine, we would have said, oh, look at what the medicine did. It shrunk the QTC. And I think that's where this perception impression of that the beta blockers shorten the QTC comes out. But so it can, propranolol can, but if we're talking about Nadolol and a baby and it looked like the QTC shrunk a lot, maybe the QTC shrunk a lot naturally because of some of the natural newborn infant changes. Oh, that's a good one, Caitlin. Thank you. Back to Instagram with Alexandra. Son started in a fitness studio. Great. Has CPVT. I'm always very afraid about it. He survived cardiac arrest, what looks like 5 years ago. He is on flecainide and beta blockers, has an ICD. No episodes, I'm guessing. So there, not much to comment on, except I'm glad to know of him as a survivor and on treatment and been diagnosed and with the expectation of living large. Now, there is some new information that has come out about the ICD in CPVT. Now, most cardiac arrest survivors, no matter what the name of their disease that we figure out afterwards, get an ICD because they did cardiac arrest. If there's one set of SADS conditions where that reflex may not be mandatory, it would be an LQT1 cardiac arrest survivor or a CPVT cardiac arrest survivor, meaning they did their cardiac arrest, but then we figured out that it was LQT1, guilty as charged. And the question is posed, doctor, do we have to have an ICD? And my answer to many of those families is no, we do not have to add an ICD, because now we know the name, and that name has a very treatable strategy without a device. So could we come up with a device-free treatment strategy even in somebody who started with cardiac arrest? The answer is actually yes. We can and we do. Now, I get it and you get it. Sometimes the emotional intensity of that cardiac arrest makes all of us say, you know what? I know you think we can treat without a device, but I'm getting one. And I get it. Many families would say, I'm glad you're that comfortable in a device-free treatment strategy, but we're going to have a defibrillator anyway. Where that matters in CPVT is making sure that that defibrillator, which is a well thought of treatment protective device, doesn't misbehave on us. And so in my CPVT patients with an ICD, I make sure that I really like their medicines. I really like their treadmill stress test on therapy. Have I cured their stress test? And if I'm not completely satisfied, Then I intensify their therapy to what we at Mayo call triple therapy with both of their medicines, beta blocker and flecainide, and the left cardiac sympathetic denervation surgery. Shile's telling me that pending results for her daughter has started on Nadolol, promising soccer player. That's wonderful. Would Nadolol or other beta blockers affect things like overall speed and endurance? Yes, perhaps. So everybody reacts differently to beta blockers. So I would never say that beta blockers make somebody a less optimized athlete, because I do have some athletes who actually think that they're a better athlete on their beta blocker. Now, would a well beta blocked patient be able to get their heart rate as high as their untreated athlete mates? No, they wouldn't, as we talked about earlier in the show. Would it impair a sprinter more than a long distance runner? Probably would impact the sprinter more. So my view on the athlete on their beta blocker with their SADS condition is as follows. The first chain reaction is, number one, do I have the diagnosis right? I don't care what kind of athlete you are. Have I made the correct diagnosis? Number two, once we have the correct diagnosis, am I pleased with your treatment strategy for that correct diagnosis? Then number three becomes, now how shall I live with that diagnosis? And how can I live and thrive despite that diagnosis? In that order, make the diagnosis correctly, get the treatment in place correctly, and then figure out, what do I do now? So once we have that in place, and if that soccer player told me, I'm LQT1, I'm on my beta blocker, and I'm no longer thriving because I don't like the way I feel on the beta blocker, then whether she's a soccer player or a trumpet player, I've got work to do. I need to optimize therapy to treat all of her, not just be focused on just making sure that the heart is beta blocked. And so I would work on those things. I do not tell athletes that, oh my goodness, you're not going to reach your dream or your destination because of the beta blocker, because your dream and your destination is going to be more determined by your drive and your discipline and your determination and your desire, not by the treatment for the diagnosis. But if despite that, they are not reaching their goals on beta blocker, and I have a beta blocker treatment alternatives that I'm equally confident in or more confident in, then we might talk about treatment, about alternative treatment strategies. A last question, just because it's a quick one from Instagram, is what's the typical time frame a person can return to sports or after having a left cardiac sympathetic denervation? In our program, where at Mayo Clinic, we do more denervations than any program in the world. Our typical drill is see me and our denervation surgeon on day one, have the surgery on day two, spend that night in the hospital almost always, 95% of the time, dismissed from the hospital on day three, go home on day four or day five. Some people stay home. So that's stay an extra day. Then they're tender in the armpit for a handful of days, but probably are returning to full training mode easily 2 weeks from the date of surgery. And that would be the typical turnaround. Well, we didn't get to all of them. We will pick up where we left off, but we are now at the top of the hour here in Rochester, Minnesota, 2 p.m. Central Time on January 10th, the second Friday of January. But for all of us, it will not be Quitters Friday. It will be continuing with our resolutions and being successful in keeping those resolutions for not just another Friday, but let's make it all year long. I intend to keep my 3 big resolutions for all of 2025. Won't you join me in being committed to your top 3 resolutions as well. So this is a wrap. Can't wait to see you in 2 weeks from today, where I'll be joined by fellow board member of the SADS Foundation, fellow genetic cardiologist, my former trainee and mentee and dear friend, Dr. Andrew Landstrom, he and I will be chatting about the top 5 research advances in the SADS conditions for 2024. Can't wait to have you join us for that. Until then, be well and let's live and thrive in 25. Bye now.